Hello and welcome to the webinar. My name is Sabrina Edgington and I'll be acting as moderator for today's webinar, Medical Respite Startups, Lessons Learned and Recommendations. This is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Office of National Assistance and Special Population. This session is being recorded. This is a 1-hour presentation with 10 to 15 minutes reserved for Q&A. To the right of the presentation slide, there's a chat box for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A selected number of questions will be answered at the end of the presentation during the Q&A session. The PowerPoint presentation and the recording of this webinar will be posted on our website, www.nhchc.org, within 72 hours. This webinar also includes additional documents that can be downloaded using the box on your screen titled Files. These materials will be available in our webinar archive along with the recording. So at this point, I'd like to introduce our presenters for today's webinar. Brandon Clark is the Chief Executive Officer at Circle the City, a standalone medical respite program based out of Phoenix, Arizona. He's a member of the Respite Care Providers Network Steering Committee and brings a wealth of experience not only from Circle the City, but also from his previous work within the largest health system in the Phoenix area. Melissa Fox is the Managing Director of Health Services for the Public Health Management Corporation's Specialized Health Services. In addition to administering the newly established shelter-based medical respite program in Philadelphia, she's also involved in a local multi-organizational efforts to improve care coordination for individuals and families experiencing homelessness and address the needs of those who frequently use hospital systems. And as mentioned earlier, I'll be moderating today's session. I'm the Director of Special Projects at the National Healthcare for the Homeless Council. I manage the day-to-day activities of the Respite Care Providers Network, and I'm currently leading a 3-year national demonstration program supported by the Center for Medicare and Medicaid Innovation to demonstrate the impact of medical respite care on health, quality of care, and system costs. I'm also your liaison at the National Healthcare for the Homeless Council for anything having to do with medical respite and supportive housing, so I encourage you to contact me if the council can be of any assistance to you in your work in these areas. So today during our presentation, I'd like to begin by outlining some of the collective startup challenges being faced by medical respite programs. I also have a couple of polls for you, and then we'll move into the presentations from Brandon and Melissa, who will describe their programs and discuss some of the lessons learned and recommendations from their own startup experiences. And then before we go into Q&A, I'll talk a little bit about some of the resources that we have that might be helpful to you in your development work, as well as some of the work that you may be doing ongoing if you're already established. So today there are over 70 medical respite programs in 28 states and in the District of Columbia. Each of these programs are very unique, and they're tailored around their own specific community needs using the resources available to them. There are also a number of programs in the planning stages that are not reflected in this map. And I'm glad to say that there's an unprecedented interest and demand in medical respite care due to the health reform goals to improve care and reduce costs, as well as the inclusion of medical respite care in the federal plan to prevent and end homelessness. So right now I'd like to present a quick poll to you, and we'd like to know where you are in your program development. Are you in your planning stages? Are you near completion in your planning stages, a new start, or have you been around for a bit? And you should be able to see a poll in front of you, and I'll just give you a couple of moments to complete the poll. And I think you can see the answers in live as they're coming in live. So we'll give it just a few more seconds. Great. So it looks like right now the majority of folks on the line are early in the planning phase. We've got 5 near completion, several who are new starts, and then we have a few that have also been around for a bit. Thank you for sharing that. That gives us some good context for how we might present some of this information. So some of the startup challenges so right now I'd like to talk a little bit about why we plan this webinar. And a lot of it is because of the range of startup challenges experienced by medical respite programs. And one of the challenges is that medical respite care is a new concept for many communities. As such, your programs may not fit neatly with local regulations related to licensing, zoning, and even certain funding streams. And funding is a huge challenge because there's currently not a targeted and sustainable funding source for medical respite programs. And often, even to propose funding for your programs, you need to demonstrate the need for medical respite care. And in many communities, the need is often based on more anecdotal information rather than quantitative information because hospitals often just aren't flagging or coding homeless patient records for reporting purposes. Medical respite programs also serve to bridge systems. They're transitioning patients from the hospital system to more appropriate primary care services, and this can be challenging when systems are not in place to seamlessly share and transition health records and health information. And that's on top of all the other barriers that our patients face in trying to navigate the healthcare system. And we're also seeing sicker and sicker patients in the medical respite care programs. And then the final challenge that we face is that there's no rubber stamp model for medical respite care programming, since each program is tailored to meet their own specific community needs and often use a patchwork of different funding sources. So the two programs that are being represented today are very unique. And I know that the images on this slide are very difficult to see, but these are the images, these program snapshots are the documents that you can download on your screen. So just real quickly, one of the programs that's being represented today is the program out of Phoenix, Arizona. And this is a large standalone facility operated by a single organization. The other is a small shelter-based facility jointly operated by two different agencies. These program snapshots offer a glimpse into each of the program's staffing, funding, capacity, and referrals. And so our next poll that we have for you is we want to know whether or not these program snapshots are helpful to you. By knowing whether or not they're helpful to you, it's going to let us know whether or not we dedicate any resources into developing these. And so you should see a poll in just a few moments, which will allow you to let us know whether or not these snapshots are anything that are useful to you in the work that you do. And feel free to be honest, it won't hurt our feelings. Great. So we see that the majority of people do think that these program snapshots are helpful. Several said that they're somewhat helpful, and a few are saying not so much. That's really good for us to know as we figure out or as we determine the products that we need to develop to help medical respite programs nationally. So I really appreciate you participating in that poll. And so we're going to go ahead and close that poll. And at this point, I'd like to hand it over to Brandon Clark from Circle the City, who will talk a little bit about his program and their lessons learned and recommendations. Brandon, to you.
Good morning. Thank you for the opportunity to present to you here today. Obviously, it's a difficult challenge to try to distill key lessons learned just down to a handful of the most potent lessons we've learned in the first few years, simply because there's been so many of them. But I'm going to try to do that exact thing here this morning in the few minutes that I have with you. Just a bit about Circle the City. Circle the City, as Sabrina mentioned, is a freestanding 50-bed medical respite center. The center was launched in October 2012 following a 5-year, $1.5 million capital campaign. A little bit about our staffing, which I'll talk more about later in my presentation. We are a 24/7 staff facility with round-the-clock nursing and medical providers on site or on call, again, 24/7. We launched with an operating budget of roughly $2.4 million, and for a variety of reasons, again, I'll discuss in a few minutes, We've now, over the first 2 years, increased that to $3.6 million. And our programmatic activity in the first 22 months of operation, we've admitted 325 unique individuals. We are proud to say that of those 325 unique individuals, over 80% of them in our first 2 years have been discharged from the respite center to somewhere other than the street or emergency shelter, which really is what makes medical respite the unique level of care that it is. I'm going to jump right into my lessons learned, and I'm going to try to keep them as simple and brief as possible. The first lesson that we learned very quickly and continue to learn today, 2 years later, is that for respite programs that depend on hospital revenue, hospital relations is a full-time job. A bit more on that point. For many respite programs, hospitals are our primary or one of our primary sources of income. The relationship building and management that needs to go into these hospital funding streams can and should be almost a full-time job. Before and after launch, I would encourage any respite program that is considering any sort of reliance on hospital funding to continuously gather data about local discharge practices and standards, which we've learned very widely by state, county, and city. You could talk, and you'll hear from Melissa here in a moment. I can tell you just in preparing this webinar, we've learned that discharge practices vary greatly between Phoenix and Philadelphia. I know from discussions with other colleagues that discharge practices in the hospitals in California are very different than discharge practices in the Phoenix area. I can also tell you that discharge practices vary by referring hospital, even in the same community. We found that there is a wide spectrum of discharge practices just in the Phoenix area alone. You should also solicit and encourage conversation about what your community's accountability for poor discharges looks like. What resources exist to create accountability, and what are the governing agencies in town that define what a safe and appropriate hospital discharge looks like. And finally, I'd encourage you to solicit hospital buy-in, as you know is absolutely necessary in the planning phases of the respite center. But I would also put, you'll see "and" is capitalized because I think it's so important to not only to solicit buy-in, but request actionable steps from any hospitals who are seeking to be involved in your medical respite center. As I say on the slide, everyone likes the idea of medical respite. You would be hard-pressed to find a hospital in town that would disagree with it in theory, but I'd encourage you to push the conversations forward. A great question to ask is, quote, what resources will be allocated during your annual budgeting process to make medical respite possible? It's one thing to like the idea of medical respite. It's another thing to take actionable steps to create capacity to support medical respite. The next slide is a summary of what I believe my learnings in regard to hospital relations are. And it simply, I'll read it to you. It says, for respite programs that contract with hospitals as a primary revenue source, your greatest market competition is substandard discharges to the street and shelter. It's very unlikely that you're going to build across town from another medical respite center. In the healthcare world, we're always concerned about who is providing a similar level of care and how do we fit into the local market. Odds are you're not going to be competing with another medical respite center, but what you are going to be competing with is hospitals, and hopefully not too many of them, who are considering the option of whether to fund placement in medical respite centers or to discharge for free to local streets or local shelters and streets where shelters aren't available. Respite centers often walk the delicate line between homeless advocate and service provider to local hospitals, and you have to be careful in furthering those conversations because in advocating for our clients, we can't appear to be self-serving in demanding respite center business. Needless to say, it's a fine line that we walk. Moving on to my second lesson learned, patient acuity really does drive your program. In the early years at Circle the City, and really in any medical respite program, I believe, no single variable will drive your program's policy, staffing needs, organizational culture more than the acuity of your patients. Patient acuity can have a huge impact on all of those things. We were naive enough when we first opened to think that we were going to completely drive acuity. And we came up with really a wonderful list of admitting criteria and common diagnoses that we anticipated that we would be caring for. But it's really interesting how hospitals and other referring partners are going to determine which of those diagnostic groups and which of those patient types they are willing to fund to come to medical respite. That brings me to the next slide, which is a graphic, and it's fairly complex, so we're going to try to ease into it here. This is a graphic that we created at Circle the City to improve communications with our hospital partners, community grantors, and board of directors about patient acuity, because this was such a huge topic of conversation for us, especially in the early years. The graphic is fairly simple. Across the horizontal axis are a set of diagnostic groups that most of our patients will fall into. Moving from left to right, anyone on the call who is a clinician by trade will see that it's moving and advancing in acuity from left to right. On the left are the patients that we would love the opportunity to take care of, who need bed rest, basic medication management, even some chronic disease management and minor wound care, but they do not meet criteria for skilled nursing. And that for us has been an important criterion distinction to make, and I'll share with you more about that in just a moment. On the right side of the spectrum, there are more advanced skilled needs, such as postoperative monitoring, trauma, the various therapies, IV infusions, and complex wounds. What we've seen, and as we build out this model, you'll see that Circle the City is only getting the opportunity to serve the right half of the spectrum. And the reason is because hospitals have no interest and do not feel any obligation to fund discharge options for patients who do not have skilled needs. And I mentioned you could almost draw a line down the middle of this continuum and define to the right would be skilled nursing, skilled medical needs, and to the left would be more custodial level of care that would typically qualify for placement directly in a home if the patient had a home. While admittedly this is an oversimplified depiction of a very complex topic, we do feel that this depicts the fact that A, local hospitals don't want to pay for patients. They don't feel legally obligated to fund to medical respite. And B, referrals to Circle the City vary widely by referring agency. You can see that we've mapped our 5 largest volume healthcare systems on this spectrum depending on who they most commonly send to us. And for example, one of our premier partners, Dignity Health, really does send us the widest variety of patients. We do get some post-ops. We do get some therapies from them in addition to the IV infusion and complex wounds. Some other partners exclusively send us the sickest of the sick. Collectively, this creates a culture of very high acuity and a patient census on any given day that is almost exclusively skilled needs. On the next slide, you can see a summary of who's being referred. As we say, hospitals want the highest return on investment, and as such will only pay Circle the City to care for the most acutely ill and injured of their patients. In the early years, we most commonly were being sent patients who fit into one of the 2 diagnostic groups you see here, either IV therapies for homeless substance abusers or complex wound care for needle-related abscesses. Obviously, this is a high-needs culture that not only needs a high level of medical oversight, but also various non-medical supports, including security, non-medical staff paying attention to them, etc. The next slide will give you a depiction then of what our staffing model looks like at launch, at the completion of year 1 and the completion of year 2, and you can get an idea of why Circle the City has grown from a $2.4 million agency to a $3.6 million agency in such a short amount of time. I draw your attention to the darker rows across left to right. The first row shows you the clinic hours. We opened with an expectation that we would be operating our clinic on site 5 days a week for 10 hours a day, and almost immediately expanded it to 12 hours a day and 7 days a week. And you can see that's how it stands today. The third row down depicts our staff RN. Initially, we hoped our RN manager would be providing all RN services, but with the prevalence of advanced wound and PICC lines, we immediately had to hire a staff RN in year one to supplement the time and attention of our RN manager. We also most recently, going into the second year of operation, have made the decision to expand nursing to night hours. So you can see the addition of a nighttime LPN predominantly to help with the relatively complex medication regimens that are being administered overnight. Moving on to our third lesson learned, this is a very broad statement, but it's very true that licensure can be tricky. And Circle the City and many other burgeoning programs have to make a decision very early on about whether you're going to pursue a license, specifically most of the time with your state Department of Health. Circle the City, just to let you know what we do, the state, after a series of dialogues with the state in the years leading up to our opening, the state made the decision to issue us a license known as an unclassified healthcare facility license by the state of Arizona. Circle the City, in the course of our first 2 years, have also held an outpatient treatment center license. We recently decided to let that one lapse, and we are expanding the unclassified healthcare facility to cover the scope of our entire program. Although the unclassified healthcare facility is a relatively simple licensure, it is still subject to about 60 pages of Arizona licensure statute, which covers the management of human resources, the environment of care, clinical policy, medication management, etc. I've been asked a number of times by organizations looking to launch a center whether or not I think that you should take a look at medical respite. The last three bullets are simply my opinion. I don't know that there's a right or wrong answer to this. But in my opinion, it may be tempting initially to fly under the radar with regard to your licensure. The risks of doing so can be rather large. As it says on the slide, even an unclassified license breeds credibility in the local healthcare community, which we've benefited greatly from in our early years. I would also challenge you to consider whether at any point in your organization's future you would like to pursue Medicaid funding of any sort. We'll talk about that in just a moment in my next lesson learned. But I will state that as we've begun to pursue Medicaid funding to supplant hospital funding here at the Respite Center, the fact that we had a license, even though it wasn't a widely understood formal medical license, it has been tremendously helpful in giving us credibility with the health plans off the bat. Third-party payers usually do require some sort of licensing. We are not currently going to be leveraging our license to secure any billing, which means that we're not eligible for any facility-based reimbursement like a skilled nursing facility or assisted living facility would be. We are going to be leveraging our professional medical group and billing exclusively professional fees in our early days of Medicaid. But again, I would stress the unclassified healthcare facility license got us a seat at the table with the Medicaid plans that we're now in advanced dialogue with. Above all, I would encourage frequent, early, and ongoing dialogue with your state licensing department. I just can't stress enough that it's not worth the risk, in my opinion, to launch a medical respite program that could potentially run into snags after opening with your state licensure department. My fourth and final key lesson learned is that you must be willing to adapt your business plan to the ever-changing healthcare environment. Circle the City, in our short time in existence, has really experienced a roller coaster ride with regard to the Arizona healthcare market, which has experienced some major changes related to the Affordable Care Act, specifically in our new state budget this year. To give you a brief overview of what's going on in Arizona, from the launch of Circle the City in October 12 through December of 2013, we served a predominantly uninsured population to the tune of more than 85% of our population was not eligible for insurance of any sort. In January 2014, as part of Arizona's new annual budget, Arizona expanded Medicaid to cover childless adults up to 133% of federal poverty level. This change, while positive for all of the clients we serve, has turned our previously successful business model on its head. Hospitals are no longer interested in funding medical respite for any patients who are now insured, even if it's just basic Medicaid insurance. This has created a phenomenon in which Arizona boasts a huge number of overly insured, underserved homeless individuals. Patients who would previously have been funded to come to medical respite are now being sent to the street and shelter just because they have some sort of Medicaid coverage, even if the Medicaid coverage doesn't allow for a reasonable discharge option. We're also now getting back to the important delineation of whether patients have skilled or unskilled medical needs at discharge. Patients who have skilled medical needs qualify for placement in Medicaid-funded skilled nursing facilities. This is obviously done at no cost to the hospital, so it's much more attractive than medical respite. These skilled nursing facilities now are trying to take homeless patients for 24 to 30 days, billing their insurance plan until the benefit runs up, and then make a pro bono charity referral to Circle the City. So you can imagine that that's created some interesting conversations here locally. But the truth is that at no point in Circle the City's existence in the past 2 years have lower acuity homeless patients qualified for any sort of placement at Circle the City because of the discharge practices of the surrounding hospitals. And we certainly hope to be changing that conversation. That's our greatest challenge in years to come. The next slide depicts a very simple couple of key metrics to give you an idea of how dramatically our operating environment changed from calendar year 2013 to 2014. Our Medicaid case mix at the time of opening through 2013 was less than 15%. In fact, our entire insured population was less than 15%. Well, this past month, we posted a Medicaid case mix, or Medicaid eligible case mix of 80%, and we are above 75% for the entire calendar year 2014. You can also see the impact this has had on average hospital revenue on a monthly basis. In the fourth quarter of 2013, we were posting between $120,000 and $140,000 in hospital-based operating income per month. That has decreased to $55,000 in the first 2 quarters of 2014. The next slide will depict, again, the familiar graphic that you've seen now a few slides ago, but it gives you an idea of what our post-Medicaid expanded environment now looks like. This is a modified version of this graphic that depicts local discharge practices in Arizona after the January 1st Medicaid expansion. So you can see the contingent of patients, again, on the right side of the highly skilled need line, are now being discharged predominantly to Medicaid-funded assisted living facilities, skilled nursing facilities, and long-term care facilities. While this is good for our patients and it gives them access to important health resources they didn't have previously, most of the time these service providers, Medicaid service providers, have no intentions of addressing a patient's homelessness. So that results in the medical need being addressed in the short term, but none of the homeless-oriented services at which the patient would be eligible for at Circle the City are available at those Medicaid-driven facilities. Circle the City underneath is there underneath the Medicaid-funded facilities. We are still seeing hospital referrals for highly skilled needs for patients who are either undocumented, have no benefits, or the benefits have already been exhausted for this plan year. So this is where we're still receiving the roughly $55,000 in hospital monthly revenue that I referenced on the last slide. We do still have an established niche with the hospital. It's just not nearly as large as it used to be. So then the challenge is, how can we sustainably serve the population that falls on the left-hand side of the acuity spectrum? These are patients who have active medical needs, who would be perfect for placement at medical respite, but currently no one is willing to fund. Our response on the next slide has been a purpose shift toward a Medicaid-driven business model. We have consciously acknowledged that the operating environment that allowed for predominantly hospital-funded respite center has changed and is effectively going away, and we have made a strategic decision to migrate from a predominantly hospital-funded model to a predominantly Medicaid-funded model. We certainly don't completely let the hospitals off the hook. They really do have a place at the table and should be considering Circle the City for placement for anyone who does not qualify for a Medicaid-funded discharge. As such, we are renewing conversations about hospital accountability toward discharge practices, but we've also adopted a strategic plan that leverages our Medicaid-heavy environment and pursues alignment with a federally qualified health center, either internally or externally in years to come. My final slide is a very, again, possibly overly simplified depiction of a complex situation. But again, these are effective communication tools in describing complex environmental changes to our various stakeholders. This graph very simply depicts Circle the City's conversion from a hospital-driven agency to a Medicaid-driven agency. And we are currently experiencing, we're in the midst of a funding gap here that we are working through with the generosity of the local community and grantors and private donors. But we're using this as a communication tool to say we're converting from a hospital-driven plan to a Medicaid-driven plan. And so far, the surrounding community has rallied behind that and understands the need for this strategic shift. Having said all of that, I'd like to thank you for the opportunity to share these learnings with you today, and I'm going to hand it off to Melissa Fox in Philadelphia. Thank you.
Thank you so much, Brandon. That was great. As we move into the slides that I'm going to review, you're going to start to hear a lot of similar themes. So whereas Brandon's program and Circle the City have been in operation for a few years now, the program here in Philadelphia, we've been in existence for about 6 months. So I'm going to talk to you about some of the things that we're seeing, but again, what you're going to hear are some clear echoes of some of the themes that Brandon just touched on in his presentation. So just to tell you a little bit about Public Health Management Corporation. So we're a larger institution. We're a regional nonprofit public health institute based here in Philadelphia. And we have over 300 programs, and they're in the areas of behavioral health. We have some social services programs, education, financial counseling, but it all focuses on targeted area of the population, the underserved population here in Philadelphia. We also are a healthcare for the homeless recipient. So under that falls within my specialized health services as well as the federally qualified health centers, and we have 5 throughout the city of Philadelphia. So all of that works very well together in serving this population, and is why Public Health Management Corporation, or PHMC, came to the table and wanted to be, or needed to be involved in these conversations about how do we create a homeless medical program, homeless medical respite program for our city. So our homeless medical respite program, it just opened or started seeing patients actively in about March of this year. Our model was a bit different. So PHMC knew going in that we needed to engage some key community partners, and one of the most important community partners that we engaged was DePaul House. So we were able to partner with them to launch this pilot, and DePaul House is a 27-room transitional shelter that's here in Philadelphia. So we were able to work with them and utilize their facility, some room they had at their facility, to get this pilot program started. It's starting out rather small with 8 beds, and we're looking to expand soon, but that's where we wanted to at least get our foot in the door and get this service operational. Similar to Circle the City, we have RN, LPN support. We have nurse practitioner oversight, as well as some physicians that will cycle through and help support our patients. And the great thing about this model is that we're able to link the patients who come through the homeless medical respite program directly to our federally qualified health center, Mary Howard Health Center here, that serves the chronic street homeless. So it's really a great match there. So in terms of how we started up in our financial support, we were very fortunate in that we received a lot of help from the City of Philadelphia, specifically the Office of Supportive Housing. They gave us the funding, provided funding to allow us to renovate the facility over at DePaul House We have some donations of beds from local organizations, and we're really able to make a nice site for our new patients. We also received some funding from the State Department of Health community-based healthcare program to support the staffing and the initial expansion. But most importantly, and this goes to what Brandon was just talking about, we started out this model with the support from our local hospitals who were seeing these homeless patients, and we were able to establish contractual relationships with them that will allow them to refer directly to the program and also help to manage the utilization of services. So, what have we learned thus far? So one of the most important lessons that we've learned, and again, in our first 6 months, is that the engagement with our community partners is extremely important for a startup. Anyone who's looking to start up a homeless medical respite program, this is where you're going to be looking to establish key relationships that are going to sustain you throughout. And I'll talk to you in a moment about what exactly that means. One of the first things is that, of course, it helps to ensure buy-in and support. For us, in Philadelphia, homeless medical respite was a brand new concept or brand new program, brand new model. So it was really important for us to get in front of the key people as early as possible who were going to be not only referring to us, but who were going to be working with us to help to transition these patients early on. For our partner hospitals, what we've done is we communicated with them up front. We engaged them in how this service was going to work with their discharge planners. So it very much was a give and take from the very, very beginning. It even goes a little bit farther back than that, though, because in Philadelphia, we began conversations with the other key providers in 2012, and a local physician, Dr. Banku, who was extremely instrumental in pulling together some of the key players. And from there, what we did was just gain everyone's input on how best to work together to enable this program to happen, to make it work. So that was really critical. It helped to build momentum for the program before it started, and once we got going, everyone was already engaged in terms of how to make it as successful and as impactful for our patients as possible. Our partners at the Office of Supportive Housing, again, continue to help us to push this forward. Another thing that we have done since we've opened is make sure that our nurse can go to the hospitals that are referring to us as often as possible to guide in the admissions process. So if there's a referral that's made and one of our nurses is able to be away, she actually goes to the hospital, helps to assess the admission, and get them to the respite as early as possible. So just keeping that door open in terms of communication has been extremely key. Kind of related to that is the education of the referral sources. So what we learned was that this should start extremely early and be an ongoing process. And again, similar to what Brandon mentioned, we're finding that this really needs to be a full-time job. And I want to call your attention to this second bullet point here because, this is something that we've learned where we started really strong, but we weren't consistent, and now we're playing catch-up. And if I could recommend anything to any of these newer programs out there, I would say that you hit the ground running with this, you allocate the resources as appropriate, and then that you maintain it. So what we did at the very beginning was we had trainings for our hospital partners, which was great. We had newsletters, we had email contacts that we were sending out, just any kind of orientation sessions that might have been needed. We also created this committee of homeless providers across the city where we were able to share ideas and talk. So that was all really strong up front and even right post-opening. But what we found was that as the level of activity picked up around the respite for our staff, the resources became really, really thin. So for that communication piece that was so critical up front, we pulled away from it as a little bit more, and we did see an impact to referrals. So that's something that now we're ramping back up, and we're trying to allocate the appropriate resources to get back in front of our community partners and make sure everyone knows that this is still here and how to properly refer. But this is something that we learned the hard lesson, and we have learned the hard lesson in that it has to be something that is totally consistent and that is continued. Another lesson that we learned, and this goes to definitely one of the things that both Sabrina and Brandon touched on, was that it's really critical at the beginning to be flexible. So I'm a planner. So I create lists, and we went into this, and the team talked about it. We have a great team, and we had a very ironclad plan in terms of the patients that we were going to see. We had a very defined admission criteria list, And we followed all those rules, and we had that very outlined, and then realized that we really had to be flexible as we move forward. Clients were more ill than what we expected. We were seeing patients who, similar to what Brandon was saying, much higher acuity than what we thought. So we had to adjust the clinical support that we had on staff. We had to work a little bit more closely with DePaul House, our partner, and make sure that after hours we had the direct contact to the additional clinicians who could help do any sort of on-call triaging that may have been needed. The staffing adjustments during the day, we also were able to, we needed to adjust according to how often people needed to go to the doctor's appointments because they were so much more ill than what we expected. So because their needs vary, we really needed to be we realized very quickly that we had to be flexible. And that's something that as we move forward, we're still continuing to tweak and we're still continuing to respond to. So this is another one similar to the upfront communication where I would say that as you go into this, it's really important to have that structure. It's really important to have that plan and that outline, but just to be aware that there will be some flexibility as you are able to determine what your particular city's needs are, because Philadelphia is different, of course, what your city's needs are, and then be able to create a model that is more responsive to the structure or the overall environment. So the next lesson is to continue to assess funding sources, and this, there's a theme here. This, again, is what you heard with Circle the City and what we are starting to see here in Philadelphia as well. So we currently have a great relationship with our existing hospital partners. As I mentioned, we work very closely with them on the referrals. We've also put something into place where there's heavy utilizer committees that they've convened, a few of them. We have volunteered a resource to go and sit there and be able to add input and add support when needed, when they're discussing these homeless patients who are cycling through their emergency rooms. So that is a wonderful relationship. Those are wonderful relationships, and we're proud of those. But in addition to that, we need to make sure that for the ongoing sustainability of the program, we have to make sure that there is a diversity of support. So we are continuing to keep the payers in the loop in terms of how this is, and they've been very responsive in terms of how the homeless medical respite program is important, how it's performing thus far. It's still very early for us, so they are looking and very interested in how it's performing, but we want to make sure that they're in the loop as well. The referrals can come from any number of different places, and then as we move forward and looking to possibly make this a part of our, or related to our FQAC in terms of a part of the scope, that is something that we're going to have to be very mindful of in terms of how that's going to be done, what licensure may be involved, et cetera. So we're at the very early stages of what Brandon is saying that he and his team have already identified as being key in terms of making sure that your funding sources are as diverse as possible so that you can have that long-term sustainability that you would need to be looking for. So that just in a nutshell is what's going on here in Philadelphia. Again, it's very early on, and I look forward to being able to share more information as we get more information, but thank you very much for your time this afternoon.
Thank you, Melissa. And before we go to Q&A, I do want to share a few resources that we have available to you. We have a number of guides, tools, and sample policies and more available through our Medical Respite Toolkit. So if you haven't browsed through those resources available through the toolkit, I encourage you to take a look at what's available so that you know it's there should you need it at any point in your work. We also maintain a directory of medical respite programs in the United States. The directory offers program profiles for over 70 medical respite programs, as well as contact information for each of the programs, and we encourage you to use the directory for peer-to-peer networking and learning. And if you haven't already, please consider joining the Respite Care Providers Network. It's free, and members of the RCPN receive a quarterly newsletter with up-to-date information about medical respite news, trends, and events. And then RCPN members also receive the occasional announcement about funding opportunities or leadership opportunities when they become available. I also want to bring to your attention an upcoming webinar. The webinar will provide an overview of proposed minimum standards for medical respite programs. This webinar will describe why standards are being developed and provide an overview of each standard. The proposed standards will be available for public review and comment on September 1. Public comments are going to be due September 30. And an email blast with a link to registration is expected to go out next week. So more information and registration will also be available on our website at www.nhcp.org. chc.org. So I encourage you to be looking out for that announcement and to participate so you can learn more about these standards and how you can provide feedback into the final set of standards that we're developing. And so now at this point, I'd like to go ahead and start the Q&A session. So we received several questions, and the first question is for both Melissa and Brandon. And Brandon, perhaps you can answer first. What are some of the reasons why an individual might be denied admission after hospital referral?
And are we looking at denials stemming from the respite center or stemming from the referring agency?
From the respite center. So what are some of the trends, some of the reasons why you might deny somebody from being admitted?
Yeah, that's a really good question and an important line in the sand for any up-and-coming center to spend some time defining. I would say the biggest reason that we deny entry to the medical respite center at the point of referral is simply because they're not stable for hospital discharge. One of our admitting criteria is that all patients are capable of conducting a majority of their activities for daily living on an independent basis. And the reason for that is because we don't provide any bedside nursing care. So patients have to be able to independently transfer out of bed and make their way over to the clinic, certainly and most oftentimes with the assistance of a wheelchair or a walker or some sort of assisting device. But that transferability has to be in play, and we simply get hospitals who are anxious to discharge, as all hospitals are, and will call us and we'll simply state, at this time denied, call us back after they've worked with PT or OT for a couple days, and we'll be able to assess then. I would say the second biggest reason would be mental instability. They're in active danger to themselves or others, or they have a history of some sorts of violence resulting from a mental diagnosis. Whereas a general rule, we are quite accepting of mental illness, but we just have to preclude that on the fact that patients are not actively a danger to themselves or others. So those would be the biggest two reasons, I think.
Great.
Yeah, ours is a little bit, it's very similar. The added thing that we have is that our facility right now is on the second floor at DePaul House. So we are very restricted in terms of, patients who are ambulatory and able to and it's not, there's no elevator, unfortunately. So those types of more ill patients who are not able to get around or get up stairs without some limited assistance, we haven't been able to accept right now. But as we expand, of course, we're going to have a facility that is a lot more accommodating in terms of those types of patients, but very similar to, the other things are pretty similar to what Brandon just stated.
Great, thank you. And so the next question is for Melissa. Did you start your program with a grant, or did you start with the state and hospital funding sources that came in? Was there a startup grant?
Yes, we did receive some funding through the state to get started, and we had some donations. So it's really a hodgepodge of things that we were able to assemble. Fortunate enough to be able to pull together to get this started, most notably, of course, being the DePaul contribution of their space. So between the state, the city providing funding for the renovation, as well as the DePaul contribution, and then some in-kind contribution from PHMC, that's how we were able to get started. But we had to be very creative in terms of moving this forward.
Great, thank you. And so the next question is, I think for both of you, what client data is gathered and shared with hospitals? Brandon?
Well, most of the client's clinical data the hospital already has because they're generating the referral. So it's not a matter of, we have standing contracts for data sharing in place with the hospitals. So any medical record, in fact, most of our patients or many of our patients come from one specific healthcare system, and our medical director is privileged in that system, so we can actually share medical record login information and seamlessly provide that continuity of care. I guess then we'd be looking at what data do we track in regards to the quality of respite programming that we should communicate back with the hospital. So we track on a patient level, admitting disposition, discharge disposition. Did they successfully complete their treatment at Circle the City? Certainly we would report back if there was either an administrative discharge or a medical advice discharge. And at discharging disposition, where were they sent, and did we effectively address the underlying issues of homelessness while they were with us? And then finally, were they connected back with a primary care physician or a medical home at the point they transferred out of Circle the City? We aggregate all of that data, and some hospitals want aggregate data for time periods such as quarterly or annually. Other hospitals are more involved and engaged in the patient-level case planning data, so we participate in phone calls, sometimes up to weekly, with our hospitals, and we review utilization and patient outcomes verbally in that manner.
And Melissa?
Yeah, similar sorts of things, the average length of stay, because of course, as a brand new program, with these hospital contracts, relatively new, they're very interested to see in how long the patients are staying with us, what are their reasons for discharge, were they, self-initiated, or was there clinical approval for release? So the primary care physician is a key bit of information that they're looking for, because that, of course, speaks to the ongoing treatment for these patients. And, another thing in addition to what Brandon just mentioned was they are very interested in where these patients are going once they are discharged. And as we're able to collect that information, we share it. The other great thing is that because we have an RN outreach staff, so we're located in about 18 shelters around the city, as well as our main health center, we're able to track these patients, and pretty much if they're going back to the street, we know where they are and how to keep in touch with them. So they are very interested in how we're continuing to manage them and manage their conditions and keep them out of the hospital.
Great, thank you. And this next question, I think, is for both of you. You've both really talked about the need for marketing and outreach of your programs. Do you have staff who are dedicated to marketing and outreach? If so, how many FTEs? What exactly is your approach to do that? And
I can go first. Oh. Go ahead, Melissa.
Well, my answer is easy. No, we don't have any dedicated outreach staff. As a matter of fact, what we are doing is training our existing outreach team or our social workers to be able to talk about this. But again, what we found is that this really is a critical piece for any new medical respite program. I would say if you do have an existing outreach staff, and this is what we're considering doing, carving out a portion of it and just have them focus on homeless medical respite and making sure that those relationships, those are potential referral relationships and the existing relationships are intact, and that everyone is aware of the program and how to connect to it. I just can't overstress that importance.
And I would answer as simply as Melissa, no. We would love to. It's not really financially viable at this point. I can tell you that half of my time in the first year was spent on that exact function, and that most recently in this year's annual budget, we have split out our admitting function. Our field-based admitting coordinator is being split out from a shared responsibility between a number of our medical team to a dedicated staff member. And our expectation is that while that individual is not actively working admissions or referrals or seeing patients at the bedside, that person that we place in that position will be doing outreach and marketing.
Great, thank you. And so this next question is for Brandon. Brandon, you talked about the high percentage of patients that were discharged to a home and not to a shelter or a skilled nursing facility. How did your team accomplish that?
Well, it's really a complex answer to a very simple question. First and foremost, we benefited in the first year and a half of a number of permanent supportive housing projects coming online in the surrounding community. We garnered relationships very quickly with those agencies that were launching the permanent supportive housing, and a number of our patients were prioritized for placement in those units. I would say that's probably 20 to 25% of that 82% number I quoted you. The others are a combination of reconnecting with family and friends. We found that the family and friends placement rate is a really good option for those that don't qualify for any housing. We also have a really strong housing voucher program for people with mental illness here in Phoenix, and we've incidentally served a quite large proportion of that population. So a number of our patients are getting housing for the mentally ill. And then I would say lastly, we have garnered some relationships with some bridge housing programs here in town. These aren't emergency shelters. These are extended transitional shelters where people pending determinations for Social Security or disability can await those decisions. And in those instances, we've also secured prioritized placement so our patients don't actually have to wait on those long waiting lists sometimes for placement in those programs. But I guess if I were to sum it up, I would say it's really important to try to, as much as you're marketing to the hospital, you almost want to spend as much time marketing to the other homeless providers in your continuum and get them excited about the idea that medical respite can be a fast track out of homelessness if you can collaborate at the community level.
Great, thank you. We have a question about joining the RCPN. I do want to let folks know that anybody can join the RCPN. You don't have to be an HCH grantee or a current medical respite provider. It's open to anyone. Our next question, and I think we have enough time for maybe one or two more. Are you looking at utilizing promotors or community health workers in your programs? And maybe we'll start with Melissa.
Absolutely. We've already started talking about how we would do that and what that would look like. So, as I mentioned, we have RNs that are currently in the shelters around the city, but we know that they are involved doing clinical care and doing other things. So we're not necessarily interested in pulling them completely away from that, but we do need an element or a person, a resource, who's able to go out after these patients are discharged from the program and ensuring that they are successful in their transition, and then being able to connect them to additional resources as needed. So we're right now looking at how we do that. Since we also have these other FQHCs, we're looking at community health workers there as well. So if there is a way for us to connect a community health worker for the Mary Howard patient base, and then tie that to what we're doing on the homeless medical respite side, that's what we're the most interested in. So we are definitely moving down that path.
In Phoenix, we haven't brought that to scale, but we did pilot a program in which 15 of the individuals who came through the respite center, who were the highest utilizers of the local healthcare system, were allocated a community health worker and placed in housing. And it was a very successful pilot, and it's got a lot of local attention. So I think as we look to expand into not only the respite world, but the outpatient care world in the coming years, I think that transitional model will be really an important part of our value proposition.
Thank you, Brandon. At this point, that concludes our Q&A. We did have a number of questions that we weren't able to get to, and what we'll do is respond to those via email, or we'll provide the responses in the archived webinar webpage when we make this webinar available in its recording. What I'd like to do is also mention to you that we have an online survey that we're asking for you to complete. Please take a minute to evaluate this webinar to let us know how we did so that we can continue to improve future webinars. I'd like to thank our speakers, Brandon Clark and Melissa Fox. Thank you so much for participating in this webinar. Any participants who have any further questions that weren't addressed, please know that we'll try to address those, and please always feel free to contact me, Sabrina Edgington, if the council can be of any help to you. And at that, our meeting is now closed. Thank you.